I again want to thank the organizers for inviting me over here. Thanks to the Yashoda Hospital and Hari. It has been a wonderful course. I'm glad the speaker just before me talked a lot about the challenges, specifically that you have to be married to the patient after you put a stent in, be available 24/7. That may not be as important when you put a Lobar stent, but we still need to understand why and if the patient needs it, if there is going to be any benefit, and what do we do if there are complications. So that's actually a logo I'd never talked about. It was designed by my colleague, Van Holden, who's my strongest partner. If somebody could advance the slide, it's not working. Oh, great. That's our medical center. I do not have any particular disclosures related to this topic. I'll start with a fundamental question when you are talking about lobar stenting. The purpose of a stent is to not only cause physiological improvement, that physiological improvement has to translate to clinical improvement. So you could make some measurements physiologically that will probably change, but is that really leading to clinical improvement? Is the patient still, and is that sustained? And these are the fundamental questions when you talk about a stent. Can you manage those complications if those happen? And can you manage those effectively? Would they require any type of surgery if things don't go well? Do you have a system or a program that can respond to those needs? And all those questions need to be answered. If the answer to any of these critical questions is you don't know, or the answer is no, you probably need to step back and ask the experts who do this day in, day out. You may have the skill set. I tell everybody, if I am practicing at a small community hospital with the skill sets I have, I would probably not be doing half the things that I do currently. So think through that comment that I just made. I think the speaker prior to me alluded very clearly, is surgery an option? If something can be fixed by surgery and takes away the recurrent problems such as recurrent pneumonia, recurrent obstruction, and you can actually shift the perfusion to the good areas, I think the problem will be better solved. So think through those. If somebody's having right middle lobe syndrome, can you do a right middle lobe lobectomy, provided there is a reasonable lung function and the patient can tolerate surgery? I suspect most of us will do the stenting in situations where that is not possible. I think Dr. Wood put it very beautifully. Stenting should be considered when it is not only technically feasible, but clinically meaningful. And I think it's behooving that we share that responsibility as a physician and an advocate for our patients. This is an example where there is little doubt when a patient has a compressed tracheobronchial tree starting from the trachea. This is after an 8.5 endotracheal tube was placed and was in place for about few hours before we took the patient. I want to point out that's the carina. It's rotated a little bit. That's the effect of the endotracheal tube compressing. But this was a near complete obstruction of the right main stem and left main stem. So in this particular patient, we took the patient for a diagnostic bronchoscopy, and on site it was small cell, and we placed a tracheobronchial Y stent, which is now available in the United States and probably available in India. It is currently marketed by Thorax Center Barnason. We removed the stent 2 weeks later. This is another example. This is left main stem over here. Near complete occlusion, patient present with shortness of breath that was subacute onset and was in the hospital for 8-10 days, not improving after antibiotics, and our oncology colleagues texted and sent an image. This is the patient who got a Bana stent in the left main stem, and you can see distally, you can see the left upper lobe and left lower lobe branch point. Patient had both physiological improvement and clinical improvement and could get to the next step of therapy. This is another example. After debulking, you still had tumor and you could not take it away safely, and we put a stent in the right mainstem. This is again a covered metallic nitinol with polyurethane covering made by Merit Endotech in the United States. Again, the patient undergoes concurrent chemoradiation therapy, and 2 weeks later, we took the stent out to prevent any further risk of infection and so on. I think there is very little debate about whether this helps if used judiciously in a multidisciplinary team fashion to promote palliation or to promote treatment and move forward and remove the stents. However, the issue comes when we are talking about benign airway stenosis, post-TB airway stenosis, post-radiation airway stenosis. Can you just manage these with balloon dilatation, gentle balloon dilatation with cryotherapy, steroid injection, and you may have, every institution has their biased protocol, and I don't want to get into debate about that, but our standard is gentle balloon dilatation, maybe a couple of electrocardiographic cuts, depending on where the critical area of the narrowing is, and then Kenalog injection thereafter, and watch and relieve the obstruction, take the suction out, treat the patient with antibiotics if need be. Most get better after you relieve that. And then give them time. Time is the biggest healer. But if that is not possible, and you believe that this is the contributing factor, a patient had clear clinical improvement, physiological improvement, and then they are getting recurrent episodes of airway obstruction and morbidity from that, that is one patient where you would think about doing a stent to probably let the healing tissue kind of form a scaffolding, or the stent be the scaffolding around which the tissue heals and then probably gives a better structure. This is a paper that I want to bring to the audience, a very well done paper, but retrospective from Cleveland Clinic. Sonali Sethi and their colleagues actually looked at this placement of ICAS stent, which is a covered stent, but with a steel mesh. So this can be balloon expanded to the shape and size you want, and I'll share that with you a little bit. They call it Lobar salvage, and many of their patients were lung transplant patients, where there is vanishing lung syndrome, and each segmental airways, predominantly segmental airways, are getting narrowed, and sometimes the bronchial stenosis. In their cohort, you can see on the left-hand side in the table, they have predominantly right middle lobe as well as left lower lobe. Again, I want you to start thinking differently when we talk about lobar stenting. Left upper lobe, left lower lobe are going to be very different. There is a lot of purchase you can get in a lower lobe in terms of landing zone compared to right upper lobe. In the distal BI going into the right lower lobe, you can have a short stent, and we can talk about length and so forth. In this particular patient, they actually demonstrate right here. There is a narrowing. They put a stent up there. They modify the ICAS by creating a hole into the covering and then gently passing a Fogarty balloon. So you could create an ostium drainage path for the segment or subsegment you're going to block. So that's the neat thing with this type of ICAS stent. When you look at, is it successful? When a patient gets a balloon dilatation after a procedure, they always feel good. In general, some patients have recoil and there is no recourse, you can't balloon dilate, but when you're talking about lobar stenting, invariably you can dilate to the size that they have physiological improvement, especially if you also do a therapeutic aspiration of the tracheobronchial tree. This retrospective paper looked at clinical improvement and pulmonary function tests after the stent was placed. Be mindful, if I open the airway, the physiology also improves. But all these patients require an average of 4+ procedures, but again, predominantly many of these patients had lung transplant. A major challenge was complications related to migration and granulation tissue. Migration was around 10%. So this is a type of stent that is available, currently used as a vascular stent, although it is FDA approved in the United States as an airway stent. So what the vascular surgeons do is they have this angioplasty balloon, over which this stent is housed, and you dial it to a nominal pressure. The neat thing about this stent is you can dial it to beyond nominal pressures and expand. Be mindful, because it's a steel meshwork, when you go beyond the nominal pressure, there is foreshortening. So if this was starting at 20 millimeter length, it probably is going to end up somewhere between 16, 17, and it's hard to predict because you don't have a full control on how much dilatation you're going to achieve. The other neat thing is, and I'm trying to see if I can go back. Yeah, so here you'll notice there's a slight flare that the procedure is created by moving the balloon proximally and expanding a little bit more to give it a flare that digs a little bit into the wall, and that's what keeps it from migrating. So the authors talk about learning curve, and that's the key part on when you deploy such a stent. The other stent that is available in the United States is an Aero Mini. This also can be deployed through a working channel of bronchoscope, and the sheath withdraws. These come in various sizes, 8 millimeter, 12 millimeter, 10 millimeter, and so on. However, be mindful that when you put a stent, the stent may be doing a lot of good, like in this case. These authors published 14 patients that were treated with a stent over a period of 7 years. What it tells you is that at an active center that is doing interventional pulmonary procedures, they did about 2 procedures per year for doing a stent that was required for a lobar stenosis. While the stent was done for middle lobe obstruction, the placement of stent itself resulted in a middle lobe pneumonia with in-stent granulation tissue, so these patients may require repeated procedures and be carefully followed. You could take out the stent. In that particular case, if I go back again on the slide, the stent is somewhat less visible, but you could use imaging and then use different types of tools to actually de-epithelialize and take it out. So be mindful if you do a stent, you've got to pay attention, and you're available 24/7 for the patients. A similar study done by the University of Pennsylvania colleagues, David DiBardino, looked into lung transplant patients. Very similar patient population, but they choose different metrics. In this particular study, they looked at the type of airway involved, and you can see a pretty reasonable distribution, just like the Cleveland Clinic study. They had less number of patients, and that is why the total number is down there. Similar to that, they created an electrocautery incision, dilated, and put a stent in to improve. In this particular situation, when the authors looked at all comers, when they compared with stented versus non-stented patient, there was no improvement in lung function. Why is that? It depends on the timing of the lung function test. So if you do it in an immediate period after you do a procedure, you're less likely to see the benefit. But if you do it close to the time when they are getting a recurrent stenosis, your physiology is going to be impaired. The other thing was there was no reduction in bronchoscopy per month, and longitudinal follow-up, there was no significant benefit. So what it tells you is that it depends on your bias to some degree. Another problem that comes is when to stent a patient. You want to stent right as they are getting worse, and if they're needing repetitive procedures. If you stent it too soon with the first procedure, you have no idea how the patient would have behaved, how their airway inflammation will have responded. Is the usual cocktail of treatment, is it working or not? And then stent complication. This is an example of a lung transplant patient who got fully covered, self-expanding Aero Mini stent. This is 1.5 weeks later when they had worsening symptoms. There was a lot of dynamic component. The patient had reduced activity despite coaching, getting in pulmonary rehab, motivating the patient to do exercise, coughing maneuvers, all that could be a challenge. We still wanted to give a try. We cleaned it out, Again, a week and a half, 2 weeks later, the same thing happened. And then we made a decision to take it out. So I'll read with you some wisdom from my mentor, Wes Shepard, that if you want to do it and must do it with caution. You need to think through all the issues that are related to placement of a stent, and I think that will be a wise decision both for you and your patient. I recognize that we have a lot of excitement, a lot of energy in the field, and this I stole shamelessly from one of the chat groups. For some, any problem can be solved with a stent. That could be a problem. And for others, the way they look at it is that this is a creative way to solve a problem with an existing solution, that's a stent. I'm happy to take any questions, and thank you very much for having me here.